Hello, my name is Maria Janet, and today we're going to discuss a case about ethical needs in palliative care patients. This presentation examines the complex case of a 72-year-old male requiring palliative care at home. He presents with worsening dyspnea and a history of multiple comorbidities, including COPD, GOLD4, alcohol-related liver cirrhosis, and hypertension. He's a smoker with a history of alcohol use and lives with his brother, who serves as his primary caregiver. The patient expresses a strong desire to avoid further hospitalization. To continue with the case, we're going to respond 4 questions about these patients and the palliative care that he needs. So the first question is it a NECPAL patient? NECPAL is a needs assessment tool used to identify patients with advanced chronic conditions who would benefit from palliative care. So, to answer this question, we need one surprise question. The one is, would we be surprised if the patient were to die in the next year? The answer is no, we wouldn't. So this patient that I already described meets criteria for NECPAL positive, indicating a limited prognosis. The second question is, according to the needs level, what needs does the patient have? First of all, we're going to navigate a little bit of what's the needs model. The needs model includes disease management, physical comfort, psychological support, social considerations, spiritual well-being, practical needs, and the end-of-life planning. So we're going to enter more deeply in this, answering the next question. What treatment would we prescribe this patient? We're going to take into account all the problems that he has and the needs that we already explained. So one of the needs is physical. The patient has these problems. He has dyspnea, he has hypoxia, he has dehydration, he has sleep disturbances, and he has anxiety. So, for example, for the dyspnea, what would we do? As medical treatment, we would give him inhaled bronchodilators, oral corticosteroids, or morphine. And as a non-medical treatment, we would tell the patient that it would be super important to have behavioral changes, as no smokers nearby. For example, say to his brother that he's not able to smoke while he's surrounding his brother. Plenty of fresh air and positional changes. For the hypoxia, we would adjust home oxygen therapy, the one that he already has at his home. For the dehydration, we would encourage oral fluid intake with water. For the sleep disturbances, we will facilitate nighttime companionship if possible. And for the anxiety, for example, we would give him low-dose benzodiazepines or morphine. In the emotional need, he has distress and hopelessness. So, to confront this, we would offer emotional support by active listening and expert psychological support. For the social needs, we have 2 problems: caregiver burden and architectural barriers. For the caregiver, we would contact external caregiver, not just his brother, and community support services. As we said, with the help of the psychologist, we would enter the patient in a community support service for him to feel more in companionship with people that are living the same that he's living. And for the architectural barriers, we would try to adapt his house the best we could through a social worker. The last need that we are going to enter into is a spiritual need. The patient has fear of future and existential suffering, the one that we would take action as making reflection and ask for a chaplain or a spiritual support. And the last problem he has is wishes regarding end of life. For this problem, we would act as a review advanced care planning and respect patients' will always respecting their autonomy and their wishes. Arriving to the last part of the presentation, we all know that conflicts arise between patients' autonomy. In this case, the desire to avoid hospitalization, and beneficence and non-maleficence, making a distinguishment between potential benefits and harms of between hospitalization versus home care. Justice, in the other hand, is also a concern due to limited access to palliative care resources, caregiver burden, and the potential inequalities in resource allocation. These are the bioethical principles: the autonomy, beneficence, non-maleficence, and justice. In this case, the patient would come into conflict with four of them, with the four of the bioethical principles. To conclude, I would like to highlight some key points of the discussion. First of all, knowing how to balance the wishes of the patient and their clinical needs is going to be essential. Not only the patient, but the caregiver is going to need adequate support too. We're going to navigate ethical dilemmas related to resource allocation and end of life care, and always consider the importance of advanced care planning and respecting patients' autonomy. In my professional opinion, I believe that the patient's autonomy, while they are complete aware of everything that is happening, is essential to take care of the case and make an excellent palliative care in this patient. This case highlights the complexities of providing palliative care in the home setting and the importance of a holistic approach that addresses the patient's physical, emotional, and spiritual needs. So, to finish, here we have the bibliography that we used to make